and welcome to Preemie Chats. Preemie Chats is a program that is for healthcare professionals and parents to talk about what matters most to us, to explore new ideas, and to learn together. I'm Leah Whitehead. I'm a proud preemie mom, and I'm also a former journalist, and I'm happy to be your host today. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation. They're also very well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a family or healthcare professional, please check out the CPBF website. There it is on the screen, canadianpreemies.org. There you will find resources, the latest projects, and most importantly, a community of people who want to see all of our little babies thrive. Today's session is live, so please bring your voice to the table. Leave comments, let us know where you're watching from, leave your questions in the chat, and we will try to address them during our program. It is through rich conversations like the one we're going to have today that advances practice and we can learn together. So please participate and let us know where you're watching from. Now on to today's topic, outcomes of preterm children born between 29 to 36 weeks gestational age. Can we enhance neurodevelopment monitoring? So most children born preterm are born between 29 and 36 weeks gestational age. While most will do well, many can experience neurodevelopmental challenges that can interfere with school readiness if no intervention is implemented. Yet, the neonatal follow-up programs mostly focus on infants who are born extremely preterm. So we're going to be joined shortly by pediatrician Dr. Thuy Mai Luu, who will review neurodevelopmental outcomes of preterm children born at later gestational ages. Then I hope you'll join us for a discussion following her presentation as we talk about how the follow-up of these forgotten subgroup could be improved. As I mentioned, Thuy Mai Luu will lead our time together today, and she's a pediatrician. She's the medical director at the CHU St. Justine Neonatal Follow-Up Program and associate clinical professor of pediatrics at the Université de Montréal. She is a clinical research scholar from the Quebec Health Research Funds. Her research focuses on long-term neurodevelopment and physical health outcomes following preterm birth, from infancy all the way up to adulthood. She looks at risk and resilience factors, along with best screening strategies to enhance clinical follow-up. She is also the director of the Canadian Neonatal Follow-Up Network. It's a research network that includes 26 neonatal follow-up programs across Canada. So she is well versed on follow-up programs, and we're very excited to have her joining us today. Welcome, Mai. Thanks for coming.
Thanks for the introduction. Well, I hope everybody can hear me well. I had some trouble hearing the introduction, so I just hope the connection gets better. So I will share my presentation. Great. So I think this is the third time I'm presenting to Preemie Chat, and it's such a great honor each time to have the occasion to share some of my clinical and I guess research knowledge with you. I think it's a great opportunity to have a conversation around different topics. So I have nothing to disclose. So as a researcher and neonatal follow-up clinician, I spend a lot of time reading and studying outcomes of children born extremely preterm. In other words, those born before 28 weeks of gestational age. And this makes sense if we think that children born extremely preterm may face more health and developmental challenges as they grow up. But However, if we take a population perspective, extremely preterm infants only make less than 1% of all live births. If we concentrate on children born moderate to late preterms, I know my talk is I mentioned in my title it was 29 to 36 weeks, but I've decided actually to concentrate on those born between 32 to 36 weeks just to make it easier. So those are the ones that we call moderate to late preterm. They actually make up 80 to 90% of the preterm population. And so and we know that the moderate to late preterm also have physiological immaturity when they are born. And so they're more likely to experience neonatal complications if we compare them to the full-term babies. And these complications may result in a prolonged neonatal state due to respiratory distress syndrome, hypoglycemia, hypothermia, jaundice, infections, apnea, or feeding difficulties. And some of these complications, such as hypoglycemia or infections, may have an effect on the developing brain. So today, my goal is to present outcomes of children born moderate to late preterm, but also to identify determinants of neurodevelopment among these children. I also want to examine the concept of developmental surveillance, screening, and assessment. And finally, I'd like to discuss how parents can be advocates for their child as part of neurodevelopmental monitoring. So let's start with neurodevelopment of children born moderate to late preterm. So what I'm showing here is, I've shown this slide in the past at the preemie talk, but what I'm trying to illustrate here is that when children are born premature during the third trimester, there are actually a lot of key neural processes which are going on. During that period, there is rapid brain growth with increasing volume of the cortex, but also growth of the cerebellum. Myelation is also taking place, as well as formation of all the brain connections that will also continue in the following months. And these processes, which are very active during the third trimester, can be altered by complications or treatments to which children born moderate to late preterm may be exposed. But these can also be affected by factors that actually occurred prior to birth, which may have led actually to the preterm birth. So I'm thinking about, for example, preeclampsia or chorioamnionitis, which is the infection of the fluid and tissue which is surrounding the fetus. So alteration in the preterm brain can later manifest as developmental delay or impairment if the developmental problems are significant enough and persisting in time. And actually, if we look at studies, it has shown that at 2 years, about 25 to 35% of children born moderate to late preterm can have developmental delay, with the language domain being more particularly vulnerable. So if we compare to full-term babies, there's actually a 2 to 4-fold increase in delay. Now, what happened later on during school age? So Deepak Lewis is a neonatologist who also has a research group in Manitoba, and he has used population-based data, so meaning data from all the children in Manitoba to examine school readiness in preterm children. And so what do we mean exactly by school readiness? School readiness is really a set of developmental and behavioral skills which are required for successful transition to school. And usually we look at 5 domains: physical health and well-being, emotional maturity, social competence, language and cognitive development, and communication skills and general knowledge to have an assessment of school readiness. And most typically, in population-based studies, we will ask kindergarten teachers to complete questionnaires based on their observation of the child in their class to assess those 5 domains. So in his study, Deepak Lewis had 4,300 preterm children. And what I'm showing here is, oops, I think I'm just going to back, oh, here, school age. school readiness, sorry. I think, yes, so sorry. So this is, I just realized that when I wrote my slide, I have this numeracy, which I don't know, doesn't make any sense, but anyhow. So in his study, what he looked at school readiness, and what he was interested in was to identify any children who might have at least one area of vulnerability in one of the 5 domains that I have shown. So in orange, yellow, you have the full-term comparison group, and you had 28% of full-term children who actually had one area of vulnerability. And if we look at the extremely preterm children, it was actually 1 out of 2. So if we look at the moderate to late preterm group, it's somewhere in between, with 1 out of 3 or 1 out of 4 children who may have some vulnerability in one area of school readiness. They also look at children who had 2 areas of vulnerability, and I've shown I've illustrated that in the other color here. So we can see that for the full term control, it's about 1 out of 6. And for the moderate to late preterm, it's about 1 out of 4 or 5 children who might have 2 areas of vulnerability prior to starting school. And we know that the more you have area vulnerabilities, the higher the risk of having some challenges with learning at school. So it's really important to identify those prior to school entries so proper support can be implemented. He also looked at school age outcomes in grade 3. And what he looked then was at numeracy and reading skills based on children who according to the teacher were needing ongoing help or were outside the range compared to the other children. So once again, like I've highlighted in black and gray, so so what you have in black is the number of children requiring support for reading, and in gray it's the numeracy, so for mathematical skills. And for the preterm groups, I've put the reading skills in red and the numeracy skills in blue. So we can see that once again, children, there's a gradient between full term and children born extremely preterm, with moderate to late preterm children sitting somewhere in between, with 1 out of 5 children requiring some extra help for mathematics or reading or being outside the range. So what it really shows is that even though most of them are actually doing well, there is a proportion of children who do require educational support at school. So what are the determinants of neurodevelopmental outcomes among children born moderate to late preterm? So in other words, among those who are moderate to late preterm, are we able to identify some risk factors or resiliency factors that will be associated with neurodevelopment? So if we look at different studies, we know that there are some perinatal and environmental factors that may warrant closer surveillance of the child. Some of them are related to factors that were associated with the preterm birth. One which is often cited is preeclampsia. Children born small for gestational age may also have more developmental challenges. Also, in terms of being admitted to the NICU, so it's not actually all moderate to late preterm who will be admitted to the NICU. You have many 35 or 36 weekers who will just be in a regular nursery. But if you were admitted to the NICU, it does mean that probably that you have had a more complicated birth and more complications afterwards. So it does make sense that you might be more at risk of developmental challenges. Hypoglycemia is another one. And in terms of environmental factor, one which always come up, not just for the premature babies, but also for the full term, are maternal postpartum depression. But if we look among children born moderate to late preterm, those who will be exposed to a mother who is having signs of postpartum depression may have more language delay. Well, it's particularly language delay that is affected. But there are also protective factors. And if you think about it, they really make a lot of sense. So one of them is breastfeeding at discharge. So children who are still being breastfed at discharge have better outcomes over the long term. And the other factors has to do with positive parenting. This was a study which was conducted in Australia and New Zealand. And so in that study, what they showed was that there were three particular features that were significantly associated with better language or social emotional development. And for this, they were assessing the parents through observation of a 15-minute play session. And what they were looking for was sensitivity, structuring, and the behavior with the child. And so greater sensitivity, which was defined as parental warmth and emotional connectedness with the child, was associated with better development. And so was greater structuring, which means parents who were able to provide appropriate guidance and scaffolding of the child's play. And also parents who were less intrusive in terms of the behavior, also actually this was associated with better developmental outcome for the child. And that was specifically the ability to follow the child's lead, giving the child the autonomy. And what I find very interesting here in the figure I'm showing is the relationship between maternal structuring and child language developmental outcome. So in the whitish zone is actually how the full terms were doing, and there was actually no relationship between maternal structuring and language outcomes in full term children. But if you look at the children born moderate to late preterm, you actually had a bunch of children who were doing as well as children born full term, and those children typically had parents who had more structuring, which shows that there are really ways that can really mitigate the impact of preterm birth on how the child is developing. And maybe it gives some ideas of what type of intervention could be proposed to families. So what I was saying, and it really, so what I've said so far really makes sense in the fact that, well, a child born moderate to late preterm is exposed to various stimuli in the NICU, which may have an effect on brain development. But I also said that actually majority of them are doing well. So how should we be doing developmental monitoring of children born moderate to late preterm? And before I go more into details, I think there are some concepts behind why developmental monitoring is important. And it's actually very simple. The idea is to identify a typical development trajectory early enough so we can initiate early intervention in a timely fashion during a period where the brain is still very plastic, meaning that the brain will be able to make new connections to compensate for injuries that may have occurred in relation to prematurity. And overall, those early interventions, there's enough evidence to show that they can really improve child functioning and quality of life if implemented early enough. So how should we do that? So as I said, well, in an ideal world, we would be maybe doing specialized neurodevelopmental follow-up in neonatal follow-up clinic for all moderate to late preterm. But the reality is, it's unrealistic due to a lack of resources. But I would probably say that it's most likely unnecessary because more than half of them will do well. So it's true that, in the early years, 1/3 can have developmental delay, but if we go up to school, 20%, actually 80% are doing pretty well. But still, there's 20% that we need to be able to track and put intervention in place at the right moment. And the problem right now is neonatal follow-up clinics have eligibility criteria that are mostly based on gestational age, but I would actually question this model because you may have a child born at 28 weeks who's doing well, who probably doesn't need specialized neonatal follow-up, but at the same time, you can have a 33-weeker who is having some challenges, but yet is not having any support in the community to be able to get access to those services. So the idea is maybe we should think about our capacity to identify early enough those who would benefit from more specialized follow-up, meaning that these children could be followed in the community, but how can we make sure that in the community, if they have concerns, they're able to send them to a specialized follow-up clinic that will do further assessment? And this surveillance could be done either at discharge from the NICU or later on in the community. So what are we talking about when we're talking about developmental monitoring? So the American Academy of Pediatrics have really set up this this process that distinguishes surveillance, screening, and assessment. So surveillance, that's the process of recognizing children who may be at risk for developmental delay. Screening goes one step further and will use standardized tools to refine that recognized risk. So that means that maybe as a family physician, I will see that this child may have language delay, but I'm not so sure because maybe my questions are not good enough. So then I can use a screening tool which is more precise in refining that risk. And if the child actually on the screening tool does screen positive for possible language delay, then it would be a good idea to refer him or her to assessment, which refers to the evaluation of the child, which is often a complex process which may involve several people to identify specific developmental disorders. And usually after assessment, we're able to implement appropriate therapy to help the child. Now, the problem is, we wish everybody would do great surveillance, but what's happening most of the time is unstructured surveillance, which can miss out up to 46 to 86% of children who have developmental delay. And those are based on studies which have been conducted in the community, not necessarily just on preterm children, but for children in general. So what we have been doing with a group of people here is to think about how we could enhance developmental monitoring in preterm infants. And my project is about children born between 29 to 36 weeks. And I'm going to present some preliminary results, but we're halfway in the study. So maybe you can invite me later so I can share more findings. But this work is being done with Marie-Noëlle Simard, who's in the middle. I don't know if you can see my arrow, but Marie-Noëlle Simard, who's an occupational therapist, and Mathieu Deas, who's a PhD with a specialty in neuroscience. And I have to acknowledge the work of Annick Cloutier, who's my amazing research coordinator. And without her, I don't think any of my projects would go anywhere. And of course, we have a great team of students and collaborators. And so in that study, what we have, and it's really ongoing right now, we've completed the recruitment of 241 infants who were born between 29 to 36 weeks and who were admitted to CHU Saint-Justin neonatal intensive care unit. We've decided to start in the NICU, knowing that based on the literature, those children were at had the higher chance of having developmental delay. So what we're doing in that study is to try to figure out, is there a way that right in the NICU in the first months of life, we're able to triage children who may benefit from being followed in the neonatal follow-up clinic for more advanced screening and assessment. So what we're doing is we're using neonatal bedside neuromonitoring through NIRS and EEG to look at the electrical activity of the brain. And we've chosen those tools because they are non-invasive and easy to do at the bedside. We're also reviewing charts to look at perinatal risk and perinatal risk factors, but also protective factors. We're also looking at the social environment with specific attention on maternal postpartum depression. And we have a physical therapist or occupational therapist who are doing infant neuromotor assessment with standardized tests like the general movement assessment, which look at how the child is moving, and also neurological examination, which are very structured, like the Amiel-Tisson neurological examination or the Hammersmith. Maybe some of you have heard about it. And so right from the NICU, we try to figure out, okay, are there some children who have a combination of factors that may warrant closer follow-up? And then what we do also is at 4 months, there's a visit that we've designed this visit that it's someone that could conduct that assessment in the community, for example, a physical therapist or an occupational therapist, or even like a trained physician, but the GMA does require significant training. And afterwards, what we're doing is we're sending questionnaires at 9 months and 18 months, the ages and stage questionnaire, and we'll come back to that. And finally, our first endpoint is developmental assessment at 24 months corrected age. And right now, we have about half of our cohort who have reached the 24 months corrected age. But we all know that 24 months might be too early, but we figured that, if we can identify developmental delay at 24 months and predict them based on factors in the NICU, that would be already a good starting point. But we've just asked for funding to continue the follow-up of this cohort to see if the markers that we are identifying in the NICU and at the first visit at 4 months also correlate with later endpoint at 4 to 5 years just prior to school entry. And we're also adding other screening measures that could potentially be implemented in the community, such as screening questionnaires, but also new technologies that use pattern recognition, the machine learning applied to a speech sample. So that's, a child just providing a speech that we record and having a machine analyzing this language to see, is it possible that this child has some language delay. And if that's the case, then it would be a good incentive to have this child assessed by a speech and language pathologist. And same thing for a pen stroke test. This is still like being under development, but the child is basically just making several pen stroke, and then the computer will analyze, is there any features with the pen stroke that suggest that this child may have some challenges with behavioral regulation or even fine motor skills that would tell the person doing this test in the community, hey, maybe you should send this child for a further assessment in occupational therapy. And then, of course, we would do an assessment. But we just asked for funding, and we're hoping that, eventually we'll get the money. So what we've found so far, so we've completed assessment. So we have half of the cohort which has complete assessment at 24 months corrected age. And some of the preliminary findings don't really necessarily come as a surprise, but if you have normal general movement assessment and normal neurological examination at term equivalent age, there's a high chance of typical development at 2 years, which is actually a good thing because, maybe it's not very complicated just prior to NICU discharge to be performing those neurological assessment. And if the child is doing well, we're reassured that, the follow-up can be done in the community. Children whose mom had symptoms of postpartum depression, we found significant association with language delay, and especially if the symptoms of postpartum depression were also continuing at the 4-month visit. So once again, we could be thinking, well, if the child is more moderate to late preterm and the mom is having some symptoms of postpartum depression, maybe this child would benefit from closer developmental surveillance and even screening to make sure that to make sure that, if there are some delays appearing, that we're supporting the family to provide the support. And also, I guess, to address, obviously, the mom's symptoms. And we've also looked at some markers of cerebral oxygen metabolism through NIRS, which is a machine that we just put some electrode to assess oxygen metabolism, and also some markers of cerebral electrophysiology through EEG that are associated with child development. But so right now we just have some preliminary findings, but the goal is to not just look at them individually, but make a combination of markers that would really help us identify children that require closer follow-up. But that's research. And in the meantime, what can we do? So we discussed previously surveillance, screening, and assessment. And actually, developmental surveillance, if it's conducted in a structured manner, as it has been recommended by the American Academy of Pediatrics, can really enhance developmental monitoring. And I guess this is a piece where, as a pediatrician, I have to do this teaching, education to family physician and in the community. But, I actually give, this talk about surveillance, screening, and assessment once a year to the community and other of my colleagues in developmental behavioral pediatrics. But this developmental surveillance has different steps, and it includes asking parents about parental concerns, assessing strength and risk, including, for example, perinatal and social risk factors, but also protective factors like breastfeeding. Then the physician should be reviewing developmental milestones and history using existing tools that can help going through those different milestones. It also includes observing the child in the office, making good documentation of what's happening, and obtaining and sharing results with others, such as early intervention or special educator. And the important thing is that surveillance doesn't occur at one time and point. It's a process which is continuous and cumulative and should be happening at each routine health visit. So it can really give a picture of how the child is evolving. And if there are some concerns raised either by parents or by the physician during the surveillance process, then screening should be happening. And I will go back to the screening. So how can we do surveillance? Well, and what can you do as a parent really to enhance that surveillance? So one of the two steps I've mentioned is really reviewing developmental milestones and history and asking about parental concerns. What many parents have told me is, especially if this is their first child, is, well, I don't really have any comparison to tell if my child is really reaching the milestones, and how do I factor in the prematurity factor? But there are actually some apps that are existing and have been recommended by the American Academy of Pediatrics. And I'm also going to show some resources that just show the different websites which can be helpful. So really, as a parent, I think you can monitor the milestones and make sure that if you have any concerns, you can report them to your doctor. And so this is an app that has been developed by the CDC. That's an American site, the Center for Disease Control and Prevention. So I've tried it yesterday because actually this is something new that has just come up over the past year. And so you basically download this app on your phone or tablet, and what you will be entering is your child information, for example, date of birth, and number of weeks of prematurity, if that's the case. And for example, I just entered, this patient, Anna, who's 13 months, but if we look at the fact that she was born preterm, the app will direct you to the right milestones. And for her, it would be the 9-month milestone tables. And so then the parent can complete a list of checklists for the 9-month milestones that look at social development, language development, cognition, and movement. And if the parent is not too sure about what that means exactly, there are actually some videos that show what we are looking for. And then the parent can answer yes, not sure, not yet, to different questions. For example, here is at 9 months, my child is shy, clingy, or fearful around strangers. My child can lift arms up to be picked up, or gets to sitting position by herself. And then once you're done with completing these milestones, there will be a summary that will tell you, awesome, Anna is on track and we should celebrate. Or, there are things that she's doing really well, but other things that it might be important that you discuss with your doctor. And then they will list which milestone should be discussed with the doctor. And it also gives some tips on activities that could be done. Well, I have to say that I've tried it, and maybe I'm not a nap person, but it was not quite intuitive at the beginning. But this is something that has just been released, and when I go through the American Academy of Pediatrics, it's really something that has been recommended. The milestones are really evidence-based, so I think we can we can trust that what has been picked as things to observe are good markers to follow development. This one comes from Canada. It's Caring for Kids from the Canadian Pediatric Society. So Caring for Kids is the website which is directed to parents. And so what it shows here are basically tables with milestones depending on age for gross motor skills, fine motor skills, social language, and cognition. So it's not an app, it's just like looking at the milestones and observing whether the child has it or not. And it does tell parents that if the child was born premature, to use corrected age. And finally, this is a website from Quebec, but it's available in English. It's Naître et Grandir, which has been developed through foundation money by many healthcare professionals. So once again, it's like the caring for kids. So you have, depending on age, different milestones that parent can check. So for example, here on the left-hand side, you have the different ages, and then you would have the different category for emotional development, fine motor skills, gross motor. And if you click on that you will have a list of things that the child are usually able to do. And that gives an idea of whether, if your child is not doing it yet, whether you should mention it to your doctor or not. So I think as a parent, if you're unsure about your child development, or if you notice that your child is actually missing a milestone, I think it's really important to share your concerns with your doctor and ask for developmental screening, which, as I mentioned previously, is a standardized and validated screening questionnaire that asks about the child development. And this questionnaire is really made in a format that once you complete those answers, it can determine whether a child needs further developmental assessment or not. Unfortunately, what I often hear, and once again, I think it's, there's also a need for education among family physician and the people in the community. But if parents have shared their concern, but then the doctor disregarded or didn't really know about it, I think as a parent, you should ask for developmental screening. If the doctor doesn't really know about developmental screening, I'm not sure how you can do, but they should be knowing, or at least ask for a referral to somewhere that are able to do some level of developmental screening. And as I said, the developmental screening process will help determine, does your child need an assessment now, or it's okay just to monitor and wait a little bit. And some of the screening questionnaires, which are widely used and are not perfect, but are probably the one which are the best right now in the clinical field, are the ages and stage questionnaires. And maybe you've heard about them. So those are parent-completed questionnaires, and they usually look at 5 domains: communication, gross motor skills, fine motor skills, problem solving, and personal social. And there are 6 items for each domain. So that makes 30 items in total. And it usually takes about 15 minutes to complete, but actually it can be faster than that. And it's also possible to complete the ASQ social emotional component, which focus more on social emotional skills and behavior. And that one takes about 10 minutes. And actually, so this is just a sample. So you see that, you have the different items for communication, gross motor, and then you just, complete whether, yes, your child is doing it, only sometimes the child doing it, or the child that is not doing it at all. And actually on the clinician side, it's very easy to score. I think within 2 minutes, you're able to score it. And then like at the end of the ASQ, you'll also have a general question. For example, do you think your child talks like other children his age? Do you think your child walks, move around like other children? So it also gives the opportunity to parents to share more general observation. And as I mentioned, after, it's really easy for the clinician to report it on this grid. And basically, there are 3 options. Either the child falls in the white area, which means that the child is developing typically. And actually, I've had some parents sometimes who would have some concern for language delay based on milestone they've looked, but then they would come to my office 2 or 3 weeks later. We would go through it into details using screening measures, and actually the child was doing well, which was reassuring. Sometimes the child can fall in the gray area, so either and that means that the child should be monitored, and another screening may be desirable in a few months. Unless sometimes actually, like if the child is in the gray area, but there are several domains which are in the gray area, and parents have a lot of concern, I think it's also reasonable at that point sometimes not to wait and refer immediately for further assessment with a physical therapist or occupational therapist or language and speech. And if the child has a domain that goes in the black area, it signifies that the child may be at risk for developmental delays and should be referred for further assessment by a professional. And why are we doing that? Well, the goal of developmental surveillance and screening is really to make sure that your child has all the support for optimal development. And sometimes in neonatal follow-up clinic, I've seen some parents say, well, my child is born preterm, so it's normal that he or she has some speech delay and he or she will outgrow it. And you know what? Yeah, it's possible that he or she will outgrow it. And I'm not sure, it's normal that the child has language delay. Maybe it is more expected compared to a sibling or a friend who is born full term. But, it's okay to refer to give the child an extra boost. And the goal really is to promote optimal development and really to foster adaptation. Unfortunately, I also hear that answer from parents who tell me, well, I've told my concern to the doctor and he said, well, it's normal, my child is born preterm. Once again, I think there's still a lot of education that needs to be done. So in summary, moderate to late preterm children may experience developmental challenges, more so than children born full term, and this can translate later on into higher educational needs. But if we do structured developmental surveillance and screening, we're able to identify atypical trajectories early enough. We're able to refer for proper developmental assessment if that's required. And so ultimately, we can put some intervention in place to optimize development and function. And I strongly believe that parents can be really good advocates by tracking developmental milestones and raising their concerns if needed. And also, I think more maybe as a community to continue promoting breastfeeding support and positive parenting as intervention that can really promote optimal development. So thank you for listening. I think I'm really keen to hear about your comments, your experience, so maybe we can think about solutions together. Thank you.
Thank you so much. I hope that you can hear me. Can you?
Yes, that's perfect.
So far, so good. We have had lots of comments and questions from people who have been watching. So I'm going to pop some of them up here. Let's see. We'll start with Nadine. She was asking, is there any consideration for length of stay in NICU, and what about apneas?
Well, that's a great question. It does make, so in studies, usually what we do is we look at the outcomes and then we put several factors. So it's possible that, the longer the child stays in the NICU, the more likely the child may have developmental delay. But then usually maybe that's not, length of stay is just the reflection that something else came up. So for example, maybe the child with a lot of respiratory problems will have a longer length of stay. So then what will pop up is not necessarily length of stay, but respiratory problems. So in the case of children born moderate to late preterm, what usually was, except for the very, the more major complications, for example, a brain bleed or serious infection, which actually don't happen so often in moderate to late preterm. The ones that were more associated with a developmental delay were hypoglycemia, not so apnea, but more, I didn't mention it, but children who had who were born to emergency C-section. Usually it's associated with children who were more sick around their birth. And it's possible that those children were also stayed longer in the NICU. But, once you put all the factors in, you realize that what has the highest weight is the hypoglycemia and actually the infections also.
We have another comment here from Elizabeth, and she was just saying, thank you for presenting on this topic. She has 3 34-weekers with intrauterine growth restriction preemies, and 2 are now in school and behind in reading and writing. We have another comment.
Yeah, so as I mentioned.
Yeah, go ahead. Can you hear me?
Yeah, so yes, I can hear you. It just cut it a little bit. So as I mentioned, we know from population-based studies that children who are born moderate to late preterm, are more likely to be behind in maths and reading. And actually, IUGR, or small for gestational age, is also a factor which is associated with language delay, developmental delay, or requiring educational needs. And the idea is really, like, I hope your child is getting the support and you're able to advocate, because what I think is, everybody have different styles of learning, but we just have to, make sure that they get all the support so they can learn even if they have those challenges. Knowing that the child is born preterm with some risk factors, maybe it's good for anticipation. So maybe, like, what I tell the family sometimes is, if you find that your child is falling behind, don't wait to ask for services. Ask it right, from the start, because we know that the child may have a greater chance of having those challenges. So I really hope that your kids are getting the support at school, because I'm sure, I truly think that all kids can do wonderful things if we give them the extra help that they need.
And Mai, would you suggest parents tell teachers at the beginning of the school year that their child was born premature?
Sorry.
Did you get that?
I'm having
I'll type
trouble
that
hearing
question.
you again.
I'll type it. We got another comment here from Haley. And she just said, this makes me so happy that this is being looked into for other families. I had felt that my son, given his complications like severe sepsis and NICU, should have been followed despite being 33 weeks. So one of those late gestational age babies we're talking about. I agree, 24 months is early. We have need for OT, PT, SLP for several delays and impairments and disorders. But they wouldn't have all been caught at 24 months. Just really thrilled this group is being seen by your study, because it can feel like these preemies are forgotten.
Yes. This is the reason why we're doing the study, because sometimes I get referral to the neonatal follow-up clinic, but the child, yes, was born moderate to late preterm, is already at 33 or 34 weeks, but is only referred to me at 3.5 years, 4 years, and I feel like maybe the child we could have implement intervention much earlier, but because it's really changing the mentality, which is difficult. So right now, it's been years and years that follow-up clinics are going by gestational age, and there's probably some research reason also behind. But for the other children, and once again, I don't think all the children needs to be followed in a follow-up clinic, but if we're able to go beyond gestational age and say, okay, yeah, this child is born at 33 weeks, but there are those factors, and actually beyond those biological or risk factors, if we do some assessment, like a neuromotor assessment at term equivalent age, we see some signs that this child might have a higher chance of developmental delay. So this child should be entered even though he's a 33 weeker. So that's really the goal of the project, to go beyond just gestational age or just like biological risk factors, but also look at maybe other markers that we get either through EEG or just like, a neurological exam that many people, trained people could do. But yeah, I totally, that's why we're doing that. And so infection and IUGR. So infections and IUGR are really in children born moderate to late preterm. We know that these children are also at greater risk. So, and I think for us at the clinic at Saint Justine, what we've decided to do is really to go case by case. So if the neonatologist or the parents feel that there are several risk factors and they don't fit the clinic, usually they send me a consultation, and then sometimes it's just a matter of seeing this child a couple of times, maybe not until school age, but if he requires follow-up until school age, to provide this follow-up. So we really go, I'm telling you about this, and at my clinic we still have entry criteria, but what we've decided to do is also to go with common sense and go by consultation. One child, especially if they have many other biological factors that may warrant closer surveillance and follow-up.
in this comment, my 35-weeker was not followed up in NICU follow-up clinic, even though they spent 3 weeks in NICU. I tried to advocate, but as an infant, our physician said it's probably not necessary.
Well, if the child is doing well, maybe it's not necessary. And actually, some parents find that in neonatal follow-up, sometimes we're a little bit intense with all our assessments, which can be also stressful. But as long as your physician is good at doing the surveillance and the screening and able to refer you if there are some concerns that arise. So, and when we did our research project, all of those children, majority of these children were followed in the community. And some actually, like when through research, if we flag something, we would obviously refer, but it was very nice sometimes to see that, oh, well, you know what, my pediatrician or my family doctor already referred me to speech because I had some concerns and he or she had some concerns. So, they were well taken care of. But I also had some patients that, we saw something and then we asked parents, well, had you also noticed? And the parent would tell me, yes, we've noticed, but, my doctor didn't do anything about it, even though it's been 6 months that I tell them that language is behind. So once again, I think that if the child is doing well and evolving well, it's okay that that's being done in the community as long as it's well done. But of course, like if there is something and there are factors that are accumulating, there's a need for the physician also in the community to have a clear pathway to be able to refer so the child has access to services. And that pathway sometimes is not so clear for a community physician.
So I hope that you can hear me, but our follow-up clinics have traditionally gone by the gestational age, like we've talked about. So should we move away from that model? Did you catch it?
I'm so sorry.
I know.
The camera stopped.
Okay.
So should we move away from the gestational age model?
Yeah.
Yes, I think so. Really, like in follow-up, also there are two aspects. So there's one aspect which is really clinical, and I think the clinical aspect should move away from gestational age. But there's also an aspect which is really also, I would say, research-based or academic-based, which means tracking how children are doing so we can report back to the NICU. And for now, I think we're tracking on the children who have the most treatments, who are experience more complications in the NICU. Right now in Canada, those are children born at 28 weeks or less, and they're being followed really for research, meaning that we have to be able to report back to the NICU and the obstetricians how the children are doing. So if there are new interventions or changes that have been made in the NICU, that we know that the child is still doing well. But if we look at the clinical aspect, I think we have to move away from gestational age. And for me, for example, and I know it's still a work in progress even in my mind, but sometimes I have the 27-weeker and here she's doing really well. I have a normal neuro exam. Well, I have to say that once the CN Fund data collection is completed at 18 months, I'll just tell the parents, I'm not going to schedule another appointment. If you have any concerns, you always can come back, but I'm not going to make those regular follow-up, which maybe are unnecessary. So at the same time, that leaves me spot for that children, who is born at 33 weeks, who might have greater developmental needs. So, but it's shifting, this way of thinking. I know at Sunnybrook, they're starting also to change, to rethink their model, and maybe they have started already doing that.
This time has been incredible. I thoroughly enjoyed your presentation, and I was writing out questions, but you were answering them even as I was writing them. It was so clear and expansive. And like we've seen from the comments today, it's something that it affects a lot of families. So thank you very much for joining us today and for presenting this.
Thank you so much for having me today. It was a great pleasure.
And thank you, everybody who's online, for joining us for today's episode of Preemie Chats. A special thank you to our sponsor, AstraZeneca, for their ongoing support of this educational program. And just a reminder that if you did miss part of today's session, then again, you can hop on over to CanadianPreemies.org, where you can watch the session in its entirety. And you'll also find all past editions of Preemie Chats. You'll find many resources and support options available there, and you'll also be reminded that CPBF, it is a charitable organization, and it depends on support to continue its important work. Consider how you can support CPBF in its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. I hope that you'll be able to join us here next Friday, again at 1 p.m. Eastern Standard Time, as we talk about responsive parenting and how that begins in NICU. I hope that everyone has a great weekend. See you again.